It's my honor to be welcoming the faculty and the students for the webinar today. It's a very special webinar being conducted by a very special person, and the lectures are all by people who have the in and out of the thoracic anesthesia. And incidentally, today is our 257th webinar, which is being conducted, as you all know, I say it every time, every Wednesday consecutively for the last 4 years. And we shall be celebrating the anniversary in July next month. You'll be getting the program for this. For some of you who may not be aware of the Indian College of Anesthesiologists, this is a body or a trust that was formed by senior members of our fraternity with the intention of imparting knowledge and awareness of our speciality throughout the world. So this college encourages all the youngsters to come, join the college and participate in its activities. Some of them for you to know is that the Indian College is holding several fellowships in different state-of-the-art institutes, which are the cornerstone of these specialities. Like we have Medanta, in which there is the Thoracic Anesthesia Fellowship, as well as the liver transplant, the Sir Gangaram Hospital, where we have the Regional Anesthesia Fellowship, the IDRA, and also the Palliative Care Fellowship. In Bangalore, we have the Dr. Indra Narayan Vidyalaya. There is the cardiac anesthesia and several more. To name a few would be onco-anesthesia as well as other fellowships. Many activities are done under the banner of the ICA. And just last month, it was conducted in Bangalore by Dr. Namrata herself on lung isolation techniques and a lot about echo, which is done regularly in the Narayan Vidyalaya. Forthcoming events, we have the annual conference of the Indian College of Anesthesiologists in the end of August, which you can see on the website. It's in Jodhpur. This is the 15th National and 6th International Conference. You should all register and join it. It is always these conferences have been getting a very good feedback, and I encourage the students to join this, to register for this conference. In addition, the Indian College also publishes a yearbook of anesthesiology, and this year we shall be releasing the 16th one. And let me tell you, students, the topics are so important and so well written that you must purchase them from JP and get a copy of it and read. It'll help you in your exams and your career. The Journal of Indian College of Anesthesiologists, the JICA, was started last year, and it is freely available online as well. So with these few words, I would like to introduce the topic today. It's Tools of Precision, Navigating the Thoracic Anesthesia Landscape. And it is with great pleasure that I would like to introduce our moderator, Dr. Sangeeta Khanna. May we have her CV slide, please? She is a very senior, of course, much younger to me, very senior lady in our fraternity, and she is the vice chairman of the Institute of Anesthesiology in Medanta, the Medicity. So this is a very big post that she is holding, and congratulations to her. She has several publications to her credit. She is a DNB teacher as well. And besides doing all thoracic anesthesia cases, they are also conducting lung transplant cases, which is a big feather in their cap. So Sangeeta, with these few words, I would like you to start the moderation of this webinar, and you may please introduce the speakers. Thank you very much.
Thank you, ma'am. Thank you for this generous introduction. And I think it's always a pleasure and honor for us to get this opportunity to conduct this webinar on thoracic anesthesia. I think most of us really enjoy doing thoracic, and we do a large volume in thoracic. So I think it gives us a great opportunity also to teach, the same thing that we are also passionate about. So to begin with, we have, basically we'll be focusing on adults because there is not too much of time. So, and every speaker has to, speak for their limited 15 to 20 minutes. And for that, we have four speakers with us, really faculty whom we've chosen across pan India, who really excel in their work. And the first topic for that today we have with us is Dr. Namrata. Dr. Namrata is the professor and former head from Kidwai Medical Institute of Oncology. She has more than 30 years of experience in onco anesthesia, and her areas of interest include thoracic, head and neck, and rehabilitation. So, to begin with, her talk will be on how we should assess our patients before we take them up for thoracic surgery. Over to you, Dr. Namrata.
Should I share my screen? Thank you so much, Sangeeta ma'am and Jayashree ma'am, for giving me this opportunity. So I'll be sharing my screen. Just a moment. So good evening, everyone. Greetings from my institute, Kidwai Memorial Institute of Oncology, Bangalore, and I've been working here from last 29 years. The topic given to me is pre-op risk assessment in thoracic surgeries. The overview of my talk would be why we do risk assessment, my three-legged stool, pulmonary function, cardiac status, recommendations, and cases posted for lobectomy and pneumonectomy. Now, Peter Slinger said that anesthesiologists are not gatekeepers. It is rarely the anesthesiologist's function to assess these patients to decide who is or is not an operative candidate. In the majority of situations, the anesthesiologist will be seeing the patient at the end of a referral chain from chest or family physician to surgeon. The question asked by Gass and Olson in 1986, what is an unacceptable surgical mortality in a disease with 100% mortality unless treated surgically, has yet to be answered. So deeming a patient operable does not necessarily imply fit for surgery. In more complex patients, there is a balance to be struck between preserving cardiopulmonary function and the potential complication of undergoing surgical resection. Why do we do this risk assessment? Primarily to identify patients at high risk for developing perioperative morbidity. Secondarily, to institute appropriate management protocols to reduce the risk. Our objectives are to ascertain after surgical resection of the lung, there will be sufficient pulmonary reserve to keep the patient comfortable and will not be a respiratory cripple. And even if the patient is posted for lobectomy or wedge resection, we should evaluate that whether he can withstand pneumonectomy or not. And if we look at the cause of perioperative morbidity and mortality in these cases, is basically because of respiratory complications being atelectasis, pneumonia, and respiratory failure, which account for the majority of mortality. Though in other kind of surgery, cardiac events are the main reason for the mortality. These are the few guidelines on which my talks are based, the main being the American College of Chest Physician Evidence-Based Clinical Practice Guidelines. Our areas of concern are age, pulmonary function, cardiovascular fitness, weight loss, nutrition, and performance status, and in terms of operability to be diagnosis or adjuvant therapy, so on and so forth by the surgeon. Coming to the age and lung cancer surgery, in elderly patient, the recommendation is that elderly patient with lung cancer who are potential candidates for curative surgical resection, it is recommended that they should be fully evaluated regardless of age. And the per-operative mortality and morbidity in a very elderly meaning more than 80 years, is definitely higher than the younger ones, and they require more attention during their prehab as well as the post-rehabilitation. Weight loss, nutrition, and performance status, the recommendations being patient presenting with a pre-op weight loss of 10% or more or a performance status of ECOG 2 or worse are highly likely to have advanced disease and require particular careful staging assessment together with the search for evidence of comorbidity. Another factor which is recommended is a simple measure of nutritional status such as body mass index together with a serum albumin measurement. Low values should be accepted as conveying an increased risk of postoperative complications. Now, the three-legged stool approach for assessment of lung resection has been used from years and is traditionally the approach used for assessing lung resection risk. Now, the three limbs are the lung mechanics, lung parenchyma, and the cardiopulmonary interaction. Now, let's look at the pulmonary function first, in which we will include the lung mechanics as well as the lung parenchyma. In lung mechanics, the predicted postoperative FEV1 more than 40%. If less, consider perfusion scan. And in parenchyma, the DLCO and the ABG. So whenever we are looking at a pulmonary function test, what is the value which we should take? We should take the best value, that is post-bronchodilator percentage of the reference value. So it is the best value of the patient which we can take is post-bronchodilator therapy. Now coming to the spirometry and diffusing capacity, traditionally the most commonly used measure is the forced expiratory volume in the first second. If it was more than 1.5 liters, directly go for lobectomy, no tests. If it is more than 2 liters, go for pneumonectomy, no tests, provided there is no evidence of interstitial lung disease or unexpected disability due to shortness of breath. But we need to focus on the calculation of predicted post-op FEV1. An absolute value of pre-op and predicted post-op FEV1 does not predict surgical outcome defined by 30-day mortality and post-operative respiratory failure. That is why we need to do FEV1, DLCO, predicted post-FEV1 and predicted post-op DLCO, expressed at percentage of predicted value correlated significantly with post-operative outcome, because absolute values can't hold good. FEV1 depends on race, age, sex, and on the height of the patient. If I take two patients, a male patient and female patient, say about 160 height or 154 centimeter, they both may have a FEV1 of more than 2 liters, but when I take percentage predicted, it will be totally different. So now the question comes, what is the correlation between FEV1 and DLCO? The correlation between FEV1 and DLCO is consistently poor, and that a reduced PPO DLCO is a predictor of cardiopulmonary complication and mortality even in patients with an otherwise normal FEV1. So you can have 40% of patients having similar FEV1 and DLCO, but 7% of them may have really different FEV1 and DLCO. So the relation is consistently poor. So what we need to do is the predicted post-operative lung function. The risk of operative complication has been totally linked to PPO lung function, which can be the forced expiratory volume in 1 second, diffusing capacity for carbon monoxide, and the percentage predicted maximal or peak oxygen consumption. And they indicate these parameters refer to the post-operative period 3 to 6 months. Now we should remember that whenever these tests are done, first the quality of the patient performance and test reproducibility must be optimal and should conform to standards. And once performance is adequate, specific attention must be directed to understanding the cause of abnormal result. So let's take an example. If there is reduction in FEV1 due to weakness, it may be associated with a different surgical outcome as compared with the patient with COPD despite having identical airflows. In addition, the presence of an obstructive endobronchial lesion may produce abnormalities on baseline testing that can be expected to improve postoperatively. So let's see how will we calculate. Now, when we need to calculate for a lobectomy, we can calculate in 3 ways. For lobectomy using segments, the predicted postoperative FEV1 will be preoperative FEV1 percentage into 1 minus number of segments removed upon 19. So total of number of segments are 19, 10 in the right lung and 9 in the left lung. If we are using sub-segments, you should know that the total number of segments are 42 in the lung, 22 in the right and 20 in the left lung. So we do it as pre-op FEV1 into 1 minus number of sub-segments removed bar 42. Doing by segments is the simplest way to do. And when we are doing with sub-segments, the sub-segments don't correlate very well with the anatomical resection. Coming to the third way is by using the number of functional or unobstructed lung segments to be removed is Y in the equation, and the total number of functional segments is Z. So we take it as predicted post-op FEV1 is preoperative FEV1 percentage into 1 minus Y by Z. But this can be only done, you can only get to know the functional or unobstructed lung segments if you do ventilation perfusion scan, and which normally is done only for pneumonectomies. The other one, that how we calculate with the perfusion scan, is the predicted post-op FEV1 and DLCO by calculating pre-op FEV1 into 1 minus fraction of total perfusion for the resected lung, similarly the DLCO. Till now, what we did were the two limbs of the stool, the lung, parenchyma, and the mechanics. Now, the third one is the cardiopulmonary interaction, where we will be seeing, we'll be doing the tests of stair climbing, shuttle walk, 6-minute walk test, and if inconclusive, considering CPET. Now, functional capacity is a strong independent predictor of survival with many factors contributing to impaired cardiorespiratory fitness. Exercise tests are used preoperatively to quantify functional capacity, diagnose the etiology of exercise limitation, evaluate cardiac risk, predict perioperative outcomes, and monitor response to prehabilitation. Cardiopulmonary exercise testing remains the gold standard. You take a detailed history and examine the patient, take a 12-lead ECG and 2D echo, then look for the thoracic revised cardiac risk index, which has 4 components: history of coronary artery disease, cerebrovascular disease, pneumonectomy, and serum creatinine. And depending on the points, more than 2 to 2.5 is a risk factor, and the highest score may being 23% and lowest score being 1.5%. So we have taken the history, the physical examination, ECG, calculated the thoracic revised cardiac index. Now, if we see, we should look for the index if it is more than 2, or a cardiac condition requiring medication, newly suspected cardiac condition, and effort tolerance less than 2 floors. If it is not there, just go ahead with your PFTs. But if it is there, what to be done? Cardiac consultation, non-invasive cardiac testing, treatment as per ACC or AHA guidelines. If there is need for revascularization, you need to postpone the surgery for 6 weeks and reevaluate. If not, then institute medical management, statins or beta blockers, and proceed to CPET and PFTs. Now, oxygen flux and ability to increase oxygen supply to meet physiological demand depends on cardiopulmonary interaction. And in the simplest form, we can measure it by using low technology submaximal test, which are stair climbing, incremental shuttle walk test, and 6-minute walk test. Stair climbing, 5 flights excellent, 2 flights or less high risk. Incremental shuttle walk test less than 400 meter or less than 25 shuttle or desaturation more than 4% considered high risk. And 6-minute walks at desaturation more than 4% considered high risk. A word about cardiopulmonary exercise testing. It records the exercise ECG, heart rate response to exercise, minute ventilation, oxygen uptake per minute. Maximal oxygen consumption, that is your VO2 max, is measured from this type of exercise test and has been recommended by guidelines. It is the gold standard for assessing oxygen reserve. A peak oxygen consumption more than 20 ml per kg per minute suggests fitness for pneumonectomy. More than 15 ml suggests fitness for lobectomy. Peak oxygen consumption less than 10 are unfit for lung resection, and the cutoff anaerobic threshold varies from 10 to 11 ml per kg per minute. Now let's see, when should we do CPET? If our predicted post-op FEV1 or DLCO is less than 60% and both are more than 30%, we will do a stair climb or shuttle walk test. Now, if the stair climb test is less than 22 meters and our shuttle walk test is less than 400 meters, we should do CPET. If our predicted post-op FEV1 or predicted post-op DLCO is less than 30%, directly do CPET. And if your positive high-risk cardiac evaluation is there, directly do CPET. How will we interpret this CPET is by the VO2 max. If VO2 max is less than 10 ml per kg per minute, high risk. If it is 10 to 20 ml per kg per minute, it is moderate risk. And if it is between more than 20 ml, it is low risk. Now whatever we have done till now, let us put it in our clinical practice. Let's look at this case 1. Jayaprakash posted for left upper lobectomy. Now, if you look at his FEV1, it is 101%. Traditionally, you can just go ahead with the surgery. But when we are calculating predicted FEV1, we are doing it FEV1 percentage into 1 minus segments to be removed upon 19. Now, 5 segments will be removed because of left upper lobectomy. Our FEV1 predicted comes 74%, which is very good. But we know that both have to be done, FEV1 as well as DLCO. His DLCO was 44%. So his predicted post-operative DLCO came to 32%, which was very less. Now, what is next? Next, we could have done, if it was a pneumonectomy, we would have just done a ventilation perfusion scan, but it was a lobectomy. So what was done by a surgeon is he changed the plan of surgery. He did segmentectomy. He removed 2 segments, and then we got a predicted DLCO of 39.36%, which was marginal. Let's look at the case 2. A 55-year-old male patient, left pneumonectomy was planned. Now his FEV1 was 51% predicted and DLCO was 50% predicted. After left pneumonectomy, the patient will be left with 10 out of 19 lung segments. So we calculated the predicted post-op FEV1 and DLCO, which were coming as 26%, which was very much less than the cutoff 40%. And the patient appears unfit for left pneumonectomy. So what next? What next is ventilation perfusion scan. And what it showed was 30% perfusion to the left lung and 87% perfusion to the right lung. So the predicted post-op FEV1 was calculated for left pneumonectomy was 40% and DLCO 44%. And both these values were above the cutoff of 40%. Therefore, this patient appeared suitable for left pneumonectomy. Now let's look at the third case. Now in the third case, what happened? She's still not yet operated. One 56-year-old female patient, case of synovial carcinoma, post-chemotherapy being posted for left pneumonectomy. Now, if we look at her PFTs, FEV1 and DLCO, we see FEV1 is 56% predicted and DLCO is 43% predicted. Now, when we calculated predicted post-op FEV1, it was 29% and DLCO 22.79%. Patient appeared unfit for a left pneumonectomy. So what was done? Ventilation perfusion scan was done. When a scan was done, the scan showed 11.7 perfusion to the left lung and 88 to the right lung. Now, what predicted post-op FEV1 value was more than 40%, good enough, but DLCO was 37.96. Therefore, patient appeared not suitable for left pneumonectomy, but this patient is a young 56-year, I would not say young, but a 56-year-old lady. So what next now? What next was we will have to go for a shuttle stair climb test, shuttle walk test or CPET. We are still waiting results for this. So after we have completed all the 3 limbs and we have put it in our clinical practice, let's have a word about the recommendation. The recommendations from American College of Chest Physicians, they have nicely been summarized in this algorithm for thoracotomy and mesenanatomical resection. So once you have done predicted post-op FEV1 and DLCO, if it is more than 60%, it's low risk. If they are between 30 to 60%, get a stair climb or shuttle walk test. Good enough, it is low risk. If they are not good enough, you do CPET and interpret depending upon the VO2 max. If your predicted post-op FEV1 and predicted post-op DLCO were less than 30%, directly go for CPET and positive high-risk cardiac evaluation, do a CPET. Now coming to another important guideline, that is the British Thoracic Society guidelines. What they said that all patients not clearly operable on the basis of spirometry should have full PFT tests including DLCO, measurement of oxygen saturation on air at rest, and a quantitative isotope perfusion scan if a pneumonectomy is being considered. They also said that this data should be able to calculate the FEV1 and TLC percentage predicted using either the lung scan for pneumonectomy or an anatomical equation for lobectomy, taking account of whether the segments to be removed are ventilated or obstructed. And in the end, they summarized by saying that estimated post-operative FEV1 more than 40% and TLCO more than 40% predicted with an oxygen saturation more than 90% is an average risk. If an FEV1 is less than 40% and TLCO also, it is high risk, and all other combination consider excise testing. Using the same predicted post-op FEV1, we can plan our extubation also. More than 40% extubate in operating room if patient alert, warm and comfortable. 30 to 40% consider extubation based on exercise tolerance, DLCO, PQ scan and associated disease. And less than 30% do a stage weaning from mechanical ventilation. Consider extubation if more than 20% plus the thoracic epidural analgesia. Before I conclude, a word about risk prediction models. So this was a systemic review where they had taken 20 models identified and they saw that the risk of bias was high for all except 2 and all externally validated models performed poorly. No model can be recommended for current use, though all of us have heard so many models like thoracoscores and all. So to conclude, when we have decided looking all that, which is low risk, moderate or high risk, the low risk will be indicates that the patient's reserve is sufficient to withstand the stress of surgery and perform daily activities in post-operative period. Risk of mortality is below 1% and major anatomic resections can safely be performed in this group. In the moderate risk, morbidity and mortality rates may vary according to the value of split function, exercise tolerance and extent of resection. And benefit of surgery is considered to outweigh the risk, and risk and benefits of the surgery should be thoroughly discussed with the patient. The high risk being the generally considered a contraindication to surgery due to the high mortality rate, more than 10% after standard major anatomic resection, and the risk of severe cardiopulmonary morbidity and residual function is expected. Patients should be counseled about alternative surgical or non-surgical options. So I would say that whatever the risk stratification we do, ultimately it is individualized, and as we saw in all the 3 examples of all the 3 cases, how the plan of management can be changed depending on the patient and the surgery. Thank you.
Thank you, Dr. Namrata. I think you have excellently covered the whole topic, and I think there is nothing that has been left untouched. So you have beautifully, with examples, illustrated how we should be using these tests. So I think we'll take all the questions if there are at the end once we have gone to the seminar. So for our next talk, as we move ahead, once we have prepared our patient and we have to go ahead for the surgery, we need to know what are the devices that we have available with us. And for that, we have no other than Dr. Akhil. Dr. Akhil is a senior consultant at Gangaram Hospital. He is also very passionate for thoracic anesthesia, and he is a member of the Airway Management Foundation, and he really loves to work around the airway. His areas of interest also include liver transplant anesthesia, and he has done a fellowship from Toronto General Hospital for lung transplant. So I'd like to invite Dr. Akhil for his talk.
Thank you, ma'am, for the kind introduction. At the outset, I would like to thank ICA and a special thanks to Dr. Jayashree Sood, ma'am, for giving me the opportunity. And thank you, Dr. Sangeeta. So I'll just now share my screen. Are my slides visible?
Yes, yeah, go ahead.
Okay. So at the outset, I would like to say I have no conflicts of interest to declare. All the videos in my presentation I have taken on my patients at Sir Gangaram Hospital, and some photos have been taken from the thoracic anesthesia textbook by Dr. Peter Slinger. So what are the absolute indications for lung transplantation? As far as the anesthesia is concerned, which we normally do OLV to allow operation on the affected lung, and we're facilitating the surgical exposure by isolating lung away from the field of surgery, like in cases of mediastinal tumors or anterior decompression of spine. So one lung ventilation is achieved by the following devices. So the gold standard for one lung ventilation are the double lumen tubes. If in any case we are unable to place a double lumen tube, we can use a single lumen tube with a built-in bronchial blocker, which is a univent tube, or single lumen tubes with isolated bronchial blockers can be used. We have various types of blockers like Arndt's blocker, uni blocker, a Cohen's tip deflecting blocker, and the latest one, the EZ blocker. And specifically in pediatric patients where neither a double lumen tube is advisable or bronchial blocker is even difficult to place, we can use an endobronchial intubation through a single lumen tube. So let's have a look at this diagram of the tracheal anatomy. So if we see that the trachea divides into two, the right mainstem bronchus and the left mainstem bronchus. Due to the peculiar anatomy of the right and the left side, a device, a double lumen tube, which is devised for the right side, cannot be inserted onto the left side. The left lung has got two lobes, the upper lobe and the lower lobe, whereas the right lung has got right upper lobe as well as a right bronchus intermedius. The right mainstem bronchus is aligned more towards in the line with the trachea, about an angle of 20-25 degrees, whereas the left one is aligned at an angle of 40 to 45. So we need to have some mechanism of ventilating the right upper lobe. So we will see for the specific design changes which are there in the DLTs of both the sides. So this is now a standard double lumen tube, the modern double lumen tube, which is a Robert Shaw type of double lumen tube, which is disposable. It is made up of PVC. It has two D-shaped lumens which are joined together, two cuffs and two inflating lines. So in this picture, if you can have a look, the right-sided double lumen tube is this one, and this is the left-sided. Each double lumen tube has got two lumens, the endobronchial one and the endotracheal one. The endotracheal one, it ends around about 5 to 6 centimeters behind the bronchial lumen. And we have a stillet, which is to be placed inside the bronchial lumen while we are inserting the double lumen tube. The double lumen tube has got two curves, the distal curve, which is between the bronchial and the tracheal end, and the proximal curve, which is like the normal curve of a standard endotracheal tube. The other, we have two openings, which can be used for bronchoscopy to confirm the adequate position of a double lumen tube. And it also comes with a ventilator connector, which is also known as a DLT connector. It has got two soft tube segments. These two soft tube segments are to be used for clamping when we do a one lung ventilation. As you can see, the bronchial cuff, whereas the bronchial end, the bronchial inflating line and the bronchial pilot balloon and even the soft segment of the bronchial is marked as blue. So not to avoid any confusion, so that while we are clamping, we are making sure that either we are clamping the tracheal side or the bronchial side. So this is, you can see the difference between the right-sided and a left-sided double lumen tube. On the right-sided tube is angled towards the right side. The left one is angled towards the left side. You have an extra ventilating slot here, which is need to be aligned with the right upper lobe. The other major difference is the type of the cuff. If you see, the left side has got a spherical cuff, whereas the right side has got a slanted donut-shaped cuff to specifically adapt to the peculiar anatomy of the right mainstem bronchus. So how do we judge what is the size of the double lumen tube? According to the landmark study by Brodsky and et al., the tracheal width is the best estimate of the size of a double lumen tube, which can be very easily measured in a post-operative chest X-ray by having the measurement of the tracheal width in between the clavicles. But we have to take all this with a little bit of caution because this data, it comes from the Western population. As with our clinical practice at Sir Gangaram Hospital, we have seen that in adult North Indian male patients, normally 37 or 35 tube size suffices, whereas in female patients, we are normally using 35 or 32. Where do we know how tube is? Before the advent of fiber optic bronchoscopy, clinical confirmation was the method of choice, in which we used to clamp the soft segment and we used to do a auscultation on the right side or the left side. But with the advent of bronchoscopy, now our motto should be seeing is believing. So what do we see in bronchoscopy? Before placing a double lumen tube, we should have a very clear idea about how our normal tracheobronchial anatomy looks like. Because in many situations where we have pus or secretions or hemoptysis, sometimes we not be able to identify the normal tracheobronchial anatomy. So even 4 or 5 important pertinent anatomical guidelines, if we know, so we should be able to place the tube. So this is basically how a trachea looks like. On the posterior aspect, is deficient in tracheal rings. There is a sharp canal bifurcation which is at 6 to 12 o'clock position, and the first generation bronchi are large with no bifurcation in sight. as we move closer towards the carina and we try to peep into the right mainstem bronchus, we can see that the right mainstem bronchus is short and it is of an average length of 2.5 centimeters and it leads directly into the right bronchus intermedius. If you see, it is going right into the bronchus intermedius. But on the 3 o'clock to 4 o'clock side, we can see the opening for the right upper lobe. So this is what a classically a right upper lobe looks like. It is the only characteristic feature in the whole of the tracheobronchial tree where you have 3 openings placed in a triangular shape fashion, which is known as a clover leaf appearance. So wherever you are going to see this opening, this 3 triangle formation, that is a right upper lobe. So when we go a little bit more distally into the right mainstem bronchus, as you can see in this picture A, we see 3 openings. This is the right bronchus intermedius. So here we are seeing 3 openings, 1, 2, and 3. And these openings are of the right bronchus intermedius, which are arranged in a vertical fashion. So this is the picture which we are going to see on the left mainstem bronchus. So in left, as the left lung has only got 2 lobes, the upper lobe and the lower lobe. So you only see 2 openings. One is for the right upper left upper lobe and one for the left lower lobe, and it is in the angulation of around about 2 to 8 o'clock position. So now how do we insert a left-sided DLT? So in this video, we are going to see that the correct anatomical position to hold the DLT is that you make the distal curve, the distal concave curve anteriorly. We do a normal laryngoscopy, and then we will first insert the blue cuff beyond the vocal cords. The moment the blue cuff is beyond the vocal cords, we will take out the stellate, and then we will rotate by 90 degrees towards the intended side. In this case, it was the left side. Then we will keep on pushing up my DLT till I encounter resistance. This, we have to be very sure that we have to not push the DLT beyond any resistance. Suppose momently we insert the DLT and just beyond passing the blue cuff, we encounter resistance. So that means the endotracheal end of the double lumen tube is unable to pass the cricoid. So that means our tube is of a larger size. On the other hand, if we keep on pushing up the tube and we are reaching the mark till 30 or 31, so that means my endotracheal aspect of the double lumen tube has gone inside the one of the bronchus. So that means I was using a smaller size tube. So how does a well-positioned left-sided double lumen tube looks? So we can very well see in this diagram. So when I do my bronchoscopy from the tracheal end, I should be able to see the sharp carina in the center, the tube going towards the left side, and I should be able to visualize the right upper lobe on the right side. And when I put my bronchoscope into the bronchial side, I should be able to see the 2 openings of the left mainstem bronchus, the upper lobe and the lower lobe. So let's have a video and see how does a bronchoscopy view looks from the tracheal side in case of a left-sided double lumen tube. So we are pushing my bronchoscope on the left side. So now I can see the carina in the center. The blue cuff was there on the left side. And this is the right side, right-sided bronchus intermedius, 3 openings in the vertical fashion. And this is the right upper lobe bronchus of the cloverleaf appearance. So this you can see very clearly. My tube is just around about 0.5 to 1 centimeters below the sharp edge of the carina, and it is going into the left side. So this appears to be a well-placed left-sided double lumen tube, but we have to also check it from the bronchial side. So let's have a look of in the same patient when we are going to do a bronchoscopy from the bronchial side. So I would like to pause the video at this moment of time. The tube which I am using is a Portex tube. So in this, when we are inserting into the bronchial side, we can also see, because the tube is transparent, I can see the carina in the center, and there is this blackish area. This is the right mainstem bronchus. So I'll go even further inside. When we go into the bronchial end, I will see the bluish cuff, the bluish area of the bronchial cuff. And when I reach the distal end, I should be able to visualize the 2 lobes of the left lung very clearly. This is the left mainstem bronchus. So this tube appears to be very nicely placed. I have adequate distance as the distal end of the tube is not abutting the secondary carina. And from the tracheal side, I am also very happy that my cuff is also inside the left mainstem bronchus. So now let's have a look at some of the common malpositions which occur in the case of a misplaced left DLT. So this is a video in which you will see that a tracheal end has gone inside the left mainstem bronchus. So now I'm doing a bronchoscopy from the tracheal side. So now I can see I'm unable to see the carina. So with a little bit of thinking that I wasn't unable to see the carina, I'm trying to pull out my tube a little bit. So now you will see I'm pulling out my tube. So now the sharp edge of the carina is now visible. So this should be now the adequate position. The other thing in this patient was that probably the tube which we have used is of a smaller size. Probably a larger size tube would have been used in this patient. So by withdrawing the tube, we have achieved the correct position. So this is another malposition in which we will see that the bronchial cuff is displaced into the trachea. So the tube is slightly inside the trachea. We need to push the tube inside. So let's have a look. As you can see that the blue bronchial cuff is lying inside the trachea. So now I will deflate my bronchial end and I will push the tube inside and I will again inflate it. So my cuff is now around about 0.5 to 1 centimeters below the level of the carina, and this appears to be a nice position, and the placement of the tube has now been corrected. So what are the indications of right-sided DLT? It is rarely required in clinical practice. In cases of isolated left lung transplant, left pneumonectomy, even left pneumonectomy can be done with the left-sided double lumen tube. You can just push out the tube when they are going to about to fire the bronchus, or left bronchial sleeve resection, or distorted anatomy of the left mainstem bronchus. So these are the various types of right-sided double lumen tubes. As you can see, in the common factor is that there is a ventilating slot which needs to be aligned for the right upper lobe, and it comes in various types of cuffs which corresponds to the anatomy of the right mainstem bronchus. So how does a well-positioned right-sided double lumen tube looks? When we see from the tracheal side, now at this moment of time, I should be able to see that my tube is going into the right side. Not on the left side, but onto the right side. And I should be, when I sing from the bronchial side, I should be able to visualize the 3 openings of the right upper lobe. So let's have a look at what does the bronchoscopy view looks from the tracheal side in case of a right-sided double lumen tube. So now, as you can see, I can see the carina in the center, and now my tube is going towards the right side. Whereas my left mainstem bronchus is empty, and I am able to visualize the secondary carina of the left mainstem bronchus. So now aligning the right upper lobe is very important. So it is very difficult. It is very challenging to apply. But if you are unable to align the right upper lobe, then we will have a loss of ventilation and it will lead to other problems. So let's have a look at the video of what does a properly aligned right upper lobe looks like. As you can see now in the distal end of this video, I am able to see the bronchus intermedius, and where you can see the gush of air which is coming out, this right ventilating slot is aligned with the right upper lobe. So this is aligned with the right upper lobe, and this is the distal bronchial end, which is the bronchus intermedius. So I would like to freeze the video this moment in time. This is the position which should be aiming for. I should be able to see the openings of the middle and the lower lobe, and my upper lobe ventilating slot is very nicely aligned with the right upper lobe. So next topic would be bronchial blockers. Bronchial blockers are not considered as gold standards, only where DLT insertion is not possible or advisable, like in cases of difficult airway or a distorted tracheobronchial anatomy, in cases of cervical spine injury, intubated patients who cannot tolerate periods of apnea, patients who are nasotracheally intubated, when only a lobe of lung needs to be blocked, and when postoperatively the patient requires elective ventilation, because it is easier to remove the blocker rather than changing a double lumen tube to a single lumen tube. So bronchial blockers can be used in all age groups, specifically useful in pediatric patients. They can be placed coaxially inside the single lumen tube or parallelly outside the single lumen tube. All have a 3-way multi-port adapter to allow simultaneous ventilation through SLT while we are inserting them. And each blocker type has its own specialized guiding mechanism for accurate placement, because the blocker needs to be directed into the left side or to the right side. So an Arndt's blocker has got a nylon wire loop, whereas the uni blocker or Coop deck have got a torque control mechanism. The Cohen has got a tip deflecting mechanism, and EZ hasn't got any mechanism. So we'll discuss about these, the two most common blockers which are available. So this is a three-way multi-port adapter. Each and every blocker has got a different type of a three-way multi-port adapter. But we have to always make sure to remember that the one port which is at 90 degrees is always used for ventilation. And we always use the straight one for bronchoscopy and the other one for the insertion of the bronchial blocker. And the third port, the fourth port is a standard female 22 ml connector which is attached to the single lumen tube. So this is the most commonly used blocker in adults at this moment of time. This is called as an EZ blocker or an easy blocker. It is a disposable 4-lumen balloon-tipped catheter, which comes in one size, 7 French. It is 75 centimeters in length with a bifurcated distal end. As you can see that the distal end of this blocker, it is Y-shaped. It has got two cuffs. One is green and one is blue. So the simple mechanism of an EZ blocker, which is described, is that you insert it blindly inside the single lumen tube, and you do a fiber optic to check that which side the blocker has gone, on which side the green side is, on which side the blue side is, and correspondingly you can inflate and block that particular side. So that is why it is called as an easy blocker or an EZ blocker, that it does not require any guiding mechanism. So this is how in a patient after an EZ blocker it looks like. You can see that the single lumen tube is coming. The specialized three-way adapter is connected. The EZ blocker in its place, and this is the locking mechanism for the EZ blocker. And we can do a fiber optic bronchoscopy from this particular port. And our ventilation circuit is attached to the port which is at 90 degrees. So while we are placing the blocker, we can also ventilate the patient. So let's have a look at the insertion of an EZ blocker. So I'm inserting my EZ blocker inside. So the moment I encounter resistance, I will stop because the V shape of the EZ blocker is now going to engage onto the carina. So as now we can now see the right side. This is the right mainstem bronchus, and we can see that here is the blue cuff which is lying. So I'm now inflating now the blue cuff. So if I want to block my right side, I want to operate on the right side, I can I can inflate the blue cuff. And similarly, after rotating my scope, I would be able to look onto the left side where I can find the green blocker or with the green cuff. Similarly, we can inflate the left mainstem bronchus also. And if we want to operate on the left side, we can inflate the one side and we can deflate the other, and we can perform our surgery. So the other blocker is the uni blocker, or which is known as also called as in some by different companies a Coopdeck blocker or a Fuji blocker. So this blocker is a torque controlled blocker in which the guiding mechanism is over here, that when you apply a rotational force at the proximal end, the same rotational force is transmitted to the distal end. When this uni blocker is attached outside of a single lumen tube, it becomes a univent tube. So it has got a fixed hockey shaped bend on the distal end that can be rotated for easy placement and for the intended bronchus. It is available in two sizes. It is available in one in pediatric size of 4.5 and an adult size of 9 French. So let's have a look at the inserting of a uni blocker. So my blocker is going beyond the single lumen tube. As you can see now, if I want to block the right side, I'll just push my blocker onto the right side. And now I will inflate the cuff. So this will lead to a nice isolation of the right lung. And similarly, if I now want to block the left side with the same blocker, I will just withdraw it. With the torque control mechanism, I will just try and rotate the blocker to the left side, and I will push it under fiber optic guidance. And I can inflate the cuff in the left mainstem bronchus, and OLV can be achieved. So lastly, I would like to see that appropriate sizing is what is very important when you are using a blocker. The sum of the diameter of the blocker plus the fiber optic bronchoscope should be less than 70% of the internal diameter of the tube. Otherwise, you won't be able to simultaneously ventilate and place the blocker. So with this, I would like to end my talk. Thank you.
Thank you, Dr. Akhil. I think it was actually a visual narrative. We could really see, how you have placed the tubes, and I think the right side tube also, you've really shown the opening and how it needs to be aligned with the right upper lobe. I think that is what most of the people would find difficulty in doing, and the blockers, their indications. So most of the things I think you have covered in this lovely lecture, and I think those who have not been using these tubes or blockers will definitely feel inspired to use them and learn from these videos. So next, once we have intubated our patient, we need to obviously maintain them on one lung ventilation if we need to perform the surgery. And to discuss the various ventilation strategies that can be used, we have Dr. Sudha with us. Dr. Sudha is a principal consultant at Medanta, my dear colleague, who is really, again, very sincere and passionate in thoracic anesthesia and handles all her cases really beautifully. So I'll hand over to Sudha to let us know the various ventilation strategies that we can use.
Thank you so much, and thanks for the kind introduction, ma'am. And thank you, Jasri Shud, ma'am, and thank you, ICA. So without wasting much time, I'll go back on my presentation. So my presentation is on ventilatory strategies during one-lung anesthesia, choices and consequences. So I won't be going in details of one-lung ventilation pathophysiology. So what happens in one-lung ventilation is that the operated lung is collapsed and there is hypoxic pulmonary vasoconstriction in action. The lung that is going to be ventilated has tendency to get collapsed and delubricated because of the upward movement of diaphragm and mediastinal shift. So it's the ventilated lung that we are worried about and that we want to protect with our different ventilatory strategies. So acute lung injury can occur to the ventilated lung because of high FiO2s, high inspiratory stress and strain, and hypoperfusion. And the collapsed lung, that can have lung injuries in the form of ischemia, reperfusion injury, re-expansion injury, or there can be surgical injury to because of surgical manipulation, resection trauma, or lymphatic disruption. And there is a release of systemic inflammatory cytokines, or overhydration, reactive oxygen species, and patient having chemotherapy or radiation injury, that also makes them vulnerable for lung injuries. So the major concerns for one-lung ventilation are acute lung injury and hypoxemia. So there are certain risk factors for acute lung injuries, that is poor predicted post-op lung function, pre-existing lung injuries in the form of trauma, infection, chemotherapy. In female patients, we generally tend to overventilate them, giving them higher tidal volume than needed. And then there are certain procedure-related risk factors like prolonged one-lung ventilation more than 100 minutes, lung transplantation, larger resections, that is in pneumonectomy, risk of injury is more compared to lobectomy. In esophagectomy, because there is increased release of inflammatory markers and excessive transfusion or excessive perioperative fluid. So I'll be taking example of two case scenarios to understand how our ventilatory setting should be. So first case is a 60-year-old male patient weighing 100 kgs, height of 160 centimeter, a known case of right upper lobe adenocarcinoma, posted for VATS, right upper lobe lobectomy. Second case, we have a 60-year-old male patient weighing 50 kgs, height 160 centimeter, known case of bullous emphysematous lung disease, posted for right VATS bullectomy. So do we plan similar ventilator setting for both the patients to prevent ARI and hypoxemia? So we'll get an answer at the end of our presentation. So there are different ventilatory strategies that can be based on different parameters that we can set on the ventilator, that is tidal volume, PEEP, FiO2, minute ventilation, I ratio, respiratory rate, peak pressure, plateau pressure, driving pressure, mode of ventilation, and one-lung ventilation duration. I'll discuss each of them. So coming to tidal volume, traditionally what we used to do was we used to use 10 to 12 mm per kg of body weight tidal volume to 2 lung, and when it was converted to 1 lung, then also it was ventilated with the same amount of tidal volume, which proved to be deleterious for the lung. So now we have moved to protective lung ventilation, that is for 2 lung ventilation we use 6 to 8 ml per kg of body weight tidal volume, and for 1 lung ventilation we use 4 to 6 ml per kg, and it is based on predicted body weight, which is based on the height of the patient. So John K. et al. They found that low tidal volume during one lung ventilation do not worsen oxygenation or compliance. In fact, it is associated with significant reduction in postoperative pulmonary complications. Nick Hoffman, they found another way of finding, tidal volume, which is forced vital capacity divided by 8. They found that in a patient with low pulmonary compliance or a smaller lung, this suits better than what we predict based on predicted body weight. So now coming to PEEP. As soon as we give anesthesia and we give paralytic agents, our lungs have the tendency to collapse and get derecruited. So the first thing that we should do is after intubation, we should recruit. That is immediately after intubation and at least after one lung ventilation initiation and at two lung ventilation initiation. At least thrice we should do so that we improve the compliance, and then we need to maintain this recruitment with adequate amount of PEEP. So for a normal restrictive lung, we can use 5 to 10 centimeter of PEEP, and we can find which patients are PEEP responders or not. So if FEV1 is more than 72%, that means they will respond better to the PEEP that we apply. Then on the other spectrum of the cases, we have these patients with emphysematous lungs. So these patients, they tend to have auto PEEP. But this auto PEEP is not homogeneous in this distribution, it is heterogeneous in distribution. So it's safe to apply a PEEP of up to 5 centimeter of water. And we should try that our total PEEP should not be more than a lower inflection point on the compliance curve. Because if it's more than that, then there is a risk of alveolar distension and increase in pulmonary vascular resistance. But still, it is recommended that when we are giving a protective lung ventilation with low tidal volume, it should not be with zero PEEP. There should always be some amount of PEEP, and low amount of PEEP is reasonably safe even in patients with emphysematous lung diseases, and it should be titrated to the best compliance. And whenever we are re-expanding the operative lung, it should always be done with hypoxic mixture to attenuate inflammatory response. Now, Mark Ricker et al. They found that implementing an intraoperative protective lung ventilation protocol in patients undergoing lung cancer resection surgery was associated with improved postoperative respiratory outcome in the form of significantly reduced incidence of acute lung injury and atelectasis, along with reduced need for ICU care. Carlos Ferrando et al. They found that during one lung ventilation, the improvement in oxygenation and lung mechanics after an alveolar recruitment maneuver was better preserved by ventilation by using individualized PEEP with a PEEP document trial rather than standardized blanket 5 centimeter of water PEEP. Gerardo Tasman et al. They found that pulmonary ventilatory maneuver performed in dependent lung during one lung ventilation anesthesia improves oxygenation and dead space and hence compliance. So now coming to FiO2. 100% oxygen before one lung ventilation, it has advantage that it causes faster collapse of the operative lung, but it has other consequences that it can cause oxygen toxicity and it can cause absorption atelectasis. So whenever we are using 100% oxygen, we have to be very cautious and we should use it judiciously only when needed. Then on operative lung, high FiO2 can lead to ischemia reperfusion injury. And so that's why whenever we are doing recruitment of operative lung, hypoxic mixture should be used, as it is it attenuates the inflammatory response and it will prevent ischemia reperfusion injury also. The FiO2 that we can reasonably use is 0.4 to 0.8. We can further go down on FiO2 in case of lung resection surgeries when the arterial supply to that particular lobe is cut off. We can go further down on the FiO2. And we should not chase a SpO2 of 100% on one lung ventilation. Anything above 92 to 94% is reasonable, provided patient doesn't have any comorbidity, which suggests that we should have keep a higher SpO2. As far as middle ventilation is concerned, permissive hypercapnia is advisable because a higher CO2, it attenuates cytokine response, and a moderate hypercapnia, it also potentiates hypoxic pulmonary vasoconstriction, but not in extreme cases. The consequences are that it, in cases of increased intracranial pressure, pulmonary artery hypertension, reduced cardiac reserve, especially right ventricular reserve, and in arrhythmias, we have to be very careful because this will worsen the condition. Now coming to I ratio and respiratory rate, in a normal restricted lung, we can use 1:2, 1:1.5 to 1:1. In obstructive lung, because we need to give more time for expiration, so we have to use 1:2.5, and we can go up to 1:4 also. The respiratory rate 12 to 18 per minute. In obstructive lung, we use lower respiratory rate. So Mark Ritter et al., they found that a peak pressure of less than 35 centimeter of water and plateau pressure of less than 25 centimeter of water is mostly achievable in most of the cases, and it is protective. So we should try to achieve that. Now coming to driving pressure, nowadays people are giving one lung ventilation based on driving pressure because excessive inspiratory stress and strain is the factor that causes ventilatory induced lung injury. So driving pressure is basically plateau pressure minus a PEEP, and it is an independent predictor for lung injury, and it should be ideally kept less than 15 centimeter of water. So Anaesthesia et al., they found that patients having surgery, intraoperative high driving pressure and changes in level of PEEP that results in an increase of driving pressure are associated with more pulmonary complications. But recently in 2023, a randomized control trial was performed. So here, Mahak, Park et al., they found that in lung resection surgeries, a driving pressure guided ventilation improved pulmonary mechanics intraoperatively in the form of better oxygenation and better compliance, but it did not reduce the incidence of post-operative pulmonary complications compared with a conventional protective ventilation at the end of 7 days, though it reduced inspiratory pressures and better compliance and better oxygenation during surgery. So coming to mode of ventilation, it is very controversial as to what mode of ventilation to be used. So it is reasonable to use, pressure controlled ventilation, pressure control, volume guaranteed ventilation mode, because it has advantage of both volume control and pressure control. In case of volume control, what happens, for giving same amount of tidal volume, we need to reach a higher peak airway pressure as compared to pressure control. In pressure control, what happens, tidal volume remains variable. So when we use PCV-VG, we have advantages of both. If this is available, this is advisable to use it. So Junpu et al., they found that in patients undergoing thoracic surgery with one lung ventilation, pressure controlled volume guaranteed mode of ventilation may have better effect by decreasing inspiratory pressures parameters and improving arterial oxygenation than compared to volume controlled ventilation. In one lung ventilation duration, ideally it should be less than 100 minutes, but that is not under our control. But one thing that we can do is one lung ventilation can be started as close to pleural opening as possible, especially in case of open surgeries, that as it takes some time to reach pleura. And two lung ventilation to be resumed as soon as possible. Now coming back to our case scenarios. So since both the patients had similar height, so the predicted body weight will be same for both the cases. Tidal volume will also remain similar in both the cases. Respiratory rate will be a little higher in case 1 and a little lower in case 2. A PEEP of 5 to 10 centimeter of water titrated to patient's best compliance in case 1, and it should be kept around 5 or less than 5 in case 2. If I have to again titrate to maintain the desired SpO2 in both the cases, I ratio is 1:1, 2 or to 1:1 in case 1 and more than 1:2 in case 2, and pressure control volume guaranteed mode of ventilation preferred. Now coming to hypoxemia, that is second challenge that we face. So there are certain predictors of hypoxemia, that is right-sided surgery, prior contralateral resection, supine position, normal FEV1, because such patients are more prone to derecruitment as their lungs are more elastic, and patient already having poor oxygenation on two-lung ventilation, and high alveolar arterial gradient of carbon dioxide. So in case of hypoxemia, we need to follow the hypoxemia algorithm. So whenever the saturation drops, we need to increase FiO2 to 100%. If the situation is life-threatening, that is, there is any arrhythmia or STT changes, then we need to stop the surgery, resume to lung ventilation. If it's not life-threatening, then we can just have an overview. We can have a look through bronchoscope and see whether lung suppression devices are in place or not, secretions are there or not. We can do the suctioning. And for hemodynamics, we can see whether the blood pressure is adequate or not, whether any blood loss is there, then we correct that blood loss. If anesthesia depth is on higher side, we can reduce that. And if there is any right ventricular failure, we can investigate and treat that further. And to improve oxygenation on ventilation part, what we can do is we can adjust the PEEP on the ventilated lung, avoid auto PEEP, and consider lung recruitment. On the non-ventilated lung side, we can use a CPAP, oxygen insufflation, jet ventilation, or partial expansion after explaining it to the surgeon. Then for perfusion, we can selectively use inhaled nitric oxide or nebulized prostaglandins. For shunt reduction, we can ask the surgeon to compress the lung or clamp the pulmonary artery temporarily. If nothing works, then we can go on VV ECMO. So to summarize, we need to go about protective lung ventilation, and the tidal volume should be based on predicted body weight, and PEEP needs to be titrated to the best compliance and depending on the patient's lung mechanics. Respiratory rate around 15 to 18 per minute, FiO2 0.4 to 0.1 and 0.8 in one lung ventilation, depending upon the saturation. And in case of hypoxemia, we can use 100%. Then again, IA ratio depending on patient's lung mechanics, and peak pressure less than 35 centimeter of water, plateau pressure less than 25 centimeter of water, and driving pressure less than 15 centimeter of water, we should try to achieve. Then minute ventilation, a PSCO2 of 40 to 60 millimeter of mercury is acceptable, and it can even go higher in cases of severe obstruction, provided we don't have any contraindication to maintaining this higher PCO2. And motor ventilation, pressure control, volume guaranteed, followed by pressure control, followed by volume guaranteed. So this is just an overview as to how we should go about doing one lung ventilation, but it will depend solely on the patient's lung mechanics and patient's comorbidities, that what strategy we use in that particular patient. Thank you.
Thank you, Sudha, for that precise and concise ventilation strategies. You've really made it sound quite simple, but we all know what a struggle it is.
Yeah.
A patient who's not saturating well, or who's deoxygenating, or the PCO2 is high. So I think each patient is a challenge in itself, and we really have to individualize our strategies according to the patients that come to us. So as we come to towards the end of the webinar, I think we have one talk, which is from Dr. Jyotirmoy Das, which is not the usual that we do in the theater, but it is something that we are now faced with, the challenges of tracheobronchial tumors and how to debulk them. And the pulmonologists who are now coming into an interventional pulmonologist who also want to get their own role, which is a big challenge for us when they do the rigid bronchoscopies. And for that, we have Dr. Das with us, who's a director at Medanta, who's again very passionate about teaching and writing. So over to you, Dr. Das.
Thank you, ma'am. Thanks for a nice introduction. So the topic is bronchoscopic debulking of tracheobronchial growth. And as we all know that the tracheobronchial obstruction can be of various types. It can be because of a tumor, or it can be because of some stenosis, tubercular induced or post intubation, or it can be a foreign body, or it can be a blood clot that has been massive blood bleeding, and the clot has stuck, and the patient is having a central airway obstruction. So why? What is the scope of say interventional bronchoscopy in such scenarios? First is for the management of hemoptysis, because the patient might have bled a lot and there are thick clots that are obstructing the passages. And the bronchoscopy can act as a large volume suction, or as for airway protection, because we can ventilate through the bronchoscope. We can at the same time do some therapeutic procedures like cauterization of the bleeding point. The other indication is for bronchoscopy is foreign body extraction. And one more important is the biopsy of large lesions, and sometimes debulking or coring of endometrial obstruction or tumor. One more indication is the dilatation of trachea and endobronchial of the stenosis by balloon or buoy. And sometimes, if needed, they can place a stent inside to dilate to keep the airway patent. One more indication is the endobronchial ultrasound, which is used for sampling of peribronchial, mediastinal, and lung masses. And like 2013 SCGP guidelines has said that EVAS TBNA is recommended over surgical staging as a best first test. So basically, if you want to diagnose some disease, some tumor kind of some lymphadenopathy, first take an EVAS biopsy, and then you can do a surgical staging. There are certain contraindications for bronchoscopy, mainly for the rigid bronchoscopy. So one absolute contraindications can be an unstable cervical spine as well as a highly vascular supraglottic tumor, because the bronchoscope cannot negotiate this tumor. And relative like coagulopathy, cervical pathology, difficult airway, facial injuries, all those things. What the patient looks like. Generally, the patient has a typical scenario of central airway obstruction, and he is dyspneic, stridorous, tachypneic, and may have a poor respiratory function like unilateral or lower lung collapse, and the oxygen saturation may be down, and he might be on some oxygen supplementation, and generally they are elderly and higher physical ASA physical status patients. But why are we getting involved in this? Because they want us to maintain the airway during the procedure. And like rigid bronchoscopy need a paralyzed patient deeply sedated. For that, they need an anesthesiologist. And for maintenance of oxygenation, ventilation, and securing of the airway, and as well as maintain the vital parameters. And if something goes wrong, some complication happens, just assist them in the management. Is it challenging? Yes, it is challenging, and it can be life-threatening even. What are the challenges? Mainly, it can be because of airway related and ventilation related. Airway related because the patient's airway we are sharing with the interventionalist, pulmonologist, and there can be sometimes there can be fire in the airway because of the laser used or electrocautery used. Sometimes it can be a loss of airway even because the tumor fragment can be dislodged and block some subsequent bronchial segments, and there can be major bleeding inside the central airway. So we can have some airway related issues like ventilator related issues, like we should be ready for an unconventional mode of ventilation. It's not a typical closed circuit kind of ventilation because everything is open there. We don't have a leak proof system. So there are a lot of airway leak. So the bellows will fall down. We have to manually ventilate. Then patient may become hypoxemic during the procedure, and because we are not ventilating properly, there might be hypercarbia. As well as we need a deep plan of anesthesia with paralysis, but at the same time we have to maintain the hemodynamics. And it's a suspension laryngoscopy. There is a lot of stress response, and at the same time maintaining the hemodynamics is a challenge. And at the end of the procedure, we need a fully recovered patient from anesthesia. The muscle relaxation effects should be aware of nicely, and patient should be fully awake so that he can maintain and cough out the secretions, maintain the airway reflexes. So first of all, preoperative evaluation. It's the anesthesiologist that is going to be involved should be well versed with the procedure related issues. And because there are some individualized risk assessment or optimization should be done, because these patients are a little different from typical thoracic surgery patients. And we should, in the preoperative period, we should inquire about the rescue position if there is any. We should ask the patient whether the patient is more comfortable in a particular position, like lateral or prone or supine or whatever, or prop up. So we should just ask them and note it down in the preoperative assessment form that patient's rescue position is this. Because intraop, if something goes wrong, we cannot ventilate or intubate. Then at that condition, we should reverse the patient, keep the patient in that position. And the preoperative investigations are as per the standard protocol for GA as per the comorbidity. There is an incidence of 4% myocardial ischemia due to adrenergic response in rigid bronchoscopy. So in any patient who is little high risk or a cardiac patient, we should always assess for CAD and congestive heart failure. At the same time, the airway assessment is very crucial because it's a difficult airway anyway. And we should discuss with the team about some alternate airway management options like tracheostomy or something. Then the CT scan or MRI films and reports should be reviewed, and we should always go for the previous bronchoscopy report or images if it is available. So bronchoscopy should setup looks like something like this. There is a tower with the viewing monitors and everything. The bronchoscope is attached to the camera head there. And at the same time, we have these scopes, various sizes scopes, the bronchoscope, tracheoscope, and some telescopes out there. We have some paraphernalias, which I'm going to discuss later on. So this somehow looks like this. So mainly two types of scopes are available. One is flexible bronchoscope, which gives us a 120-degree field of view, and 180-degree up or 130 or 180-degree down angulation. And in a cross section, you can see that there is a working channel. There's a black channel, working channel. You can see here in this image in the middle. So there's a working channel, and there is a light fibers for the light to pass there, and there's a camera port. There's a fibers for the image to come out. So, and the black dots are for your angulation. The microscope, the fiberoptic bronchoscope can be made. The tip can be flexed up and down. So these cables manage that. Okay, now there are various sizes available. One is ultra thin, which is 2.2 to 3 millimeter thin, and then standard, and then therapeutic or large. Generally, for bronchoscopic interventions, we use the large scopes, which is 5.8 to 6.3 millimeter size. And it has a working channel. The inside channel through which the instrument goes in or out is around 2.8 to 3.2 millimeter. On top of that, we have the rigid bronchoscope, which is a metal tube, which the distal end, as you can see in the image on the right, distal end is beveled. Why it is bevel? Because while introducing, we can lift the epiglottis through the bevel, by the bevel, and negotiate a tight stricture because of the bevel thing. And we can just pour some tumor also with the bevel and take out the, we can pour out a stuck stent because of the bevel. So the bevel has many advantages. And the proximal port has a attachment for the multi-port connector, multi-port head. So multi-port head has different connections. One for the your ventilation port. Number one is the ventilation port. Number two is the optical port. Number three is the suction port or laser fiber port. So mainly two types of rigid bronchoscopes are available. One is tracheal scope. One is the bronchial scope. Tracheal scopes are a little shorter, 33 centimeter, and there does not have any fenestration. It stays in the trachea. It does not go beyond the carina. So ventilation is through the distal tip. The bronchial tubes, on the other hand, are a little longer. Bronchial, they are around 43 centimeter, and they have side holes or fenestrations. Like you can see in the image in the arrow, there are side holes or fenestrations, because when the bronchoscope goes to one bronchus, main stem bronchus, right or left, through these holes, the other bronchus can be aerated or ventilated to some extent. So these are, this is how it looks like there are various connections, and there's a tooth guard, and there are various parts. And on the right, we can see a telescope which goes through the bronchoscope or tracheoscope. There are various sizes available, like 3 millimeter pediatric scope till 18 millimeter largest adult scope. But generally, we use around 12 or 14 millimeter kind of size scopes in our adult patients. So this is the typical trolley which is being assembled for the bronchoscopies, and the flexible probe can be used in combination with the rigid bronchoscope. The flexible scope can go inside the rigid scope and do the pulmonologist can do the maneuvers through the working channel of the flexible probe. So this is a small video about a case. So there's a left main stem bronchial growth. As you can see the carina. Now the bronchoscopist is going to the right side. The right side is clean. Yeah, this is the left side. Left side we can see a tumor and the left main stem bronchus. So monitoring, first of all, what are the monitors that we can, this case comes to the OT, and now the monitoring standard part is standard 5-lead ECG, NIVP, pulse oximetry, and ETCO2 are connected, are the standard monitors. And bispectral index monitoring is ideal for these cases, because we cannot just rely on the inhalational anesthetics, because sometimes we cannot ventilate the patient properly. So we need to start an infusion of propofol or something, or remifentanil, which is available. But then for that we need a BIS monitoring. And end-tidal carbon dioxide monitoring and tidal volume monitoring are not reliable during bronchoscopy because of the circuit leak. Arterial line requirement is as per the patient's comorbidity. IV cannula is, we should have a good wide bore IV cannula. And the important part is, because we are going to give some form of TIVA, so this cannula should be visible throughout. It should not be under the drips, because we need to see whether it is going nicely, is there any swelling in the cannula or something, because otherwise we'll be in trouble, because the patient's depth will be very difficult to maintain. And what are the ideal anesthetic goals? Like pre-oxygenation is important. Smooth induction is very important because patient should not be like hemodynamically stable throughout the procedure, and there should not be a lot of secretions because if the patient will struggle with the intubation or ventilation process, the stress response goes up and there will be a lot of secretory changes, and minimal hemodynamic instability should be there. The ventilation and oxygenation is we should always check, and we should try to reduce the cuff reflexes. At the same time, the patient should be paralyzed nicely, and there should be adequate mandibular and glottic relaxation. And at the end of the procedure, there should be complete recovery and minimal perio complications. This is the standard position, like sniffing the morning air position. Conductive anesthesia, topical anesthesia can be used in the pre-op to topicalize to reduce the gag reflex and everything. Then rigid bronchoscope requires GA with muscle relaxation, as already told. Then depth of anesthesia should be adequate, ideally monitored by this. First, we pre-oxygenate the patient, and then we do the standard induction as per the protocol. LMA is inserted. Supraglottic device can be inserted, followed by rigid scope, or we can just start with a rigid scope only. And ventilatory circuit is connected to the side port. As you can see in the image, the ventilatory circuit is connected to the side port of the rigid scope. And we can use the manual ventilation with this circuit, or we can use a Z connector, Z ventilation through the side port. Maintenance of anesthesia is mainly with oxygen, air, with inhalational or propofol. Intravenous propofol or amipentalin infusion is preferred, and TCI, if available, is a welcome thing. Then stress response should be blunted with addition of, say, opioid, beta blockers, calcium channel blockers, or vasodilators. What are the approaches to ventilation? Mainly 4 approaches. One is apneic oxygenation, like during that particular process period of time when they are using a cautery or some devices which can cause airway, say this thing. So apneic with a low FiO2 can be continued, and spontaneous assisted ventilation can be a choice if the patient is tolerating well, not with specifically with a rigid scope, obviously, because in rigid we need a relaxed patient. Then control ventilation in a closed system, we can manually ventilate the patient, or with the machine, with a high airflow, if the patient is, we can just we can ventilate, then we can. Otherwise, we can do a manual with the use of oxygen flush, or we can use a high frequency jet ventilator. So where to connect the jet ventilator cannulas? We can see in the left hand image, you can see that the jet catheter is going on the side port. This is one way of doing it. The other is we can connect it to the this laryngoscope here, like in the lower image, or we can connect it to the bronchoscope or tracheoscope during that jet ventilation. What about the FiO2? FiO2 we generally keep 1 during rigid bronchoscopy because we are not very sure how much ventilation we are doing. And if cautery is used, we have to reduce the FiO2 to less than 0.4, ideally less than 0.3 if the patient can tolerate, or even for short period, we can go for apnea during a particular cautery thing to prevent airway fire. And in case of laser, we can use that laser button on and off if you are using a jet ventilator, because when you switch on the laser button, the FiO2 automatically goes down to 30%. The gadgets that are the pulmonologists will use during the procedure is, one is electrocautery, because it can cut, coagulate, and vaporize the target tissue depending on the power setting. Instruments that they can do the electrocautery by rounded probes, by snares, by knives, or by hot forceps. And this electrocautery can be used through the flexible or as well as the rigid bronchoscope. And the only contraindication is probably, or relative contraindication is pacemaker patients. For this electrocautery, you can see there, this is the left-hand side is the tumor. On the right, they have done the electrocautery of the tumor. Other important modality they use is argon plasma coagulation, APC. And for that, they have this machine, and they use argon to basically do the cautery. And the important thing is that the argon tip APC probe tip does not touch the tissue. It remains at a distance of, say, ½ centimeter. So through that, they can do that, and it does not need a contact with the tissue. Because why they don't, ideally it should not touch the tissue, because this argon gas can accumulate in the tissue, and when it goes to the blood circulation, it can form emboli, like bubbles in the vasculature, and that it can migrate and cause embolism. And there are reports of systemic embolization after argon laser. So they always keep it at a distance. And important thing to remember with argon APC is that it can cause airway fire, and it can even cause airway perforation and gas embolism, as I had already discussed. And direct mucosal contact with the APC probe can result in submucosal gas deposition and gas entering the intravascular space. Another modality is the cryoprobe. Cryoprobe is they use this cylinder like carbon dioxide or nitrous. So they use it. This is the cryoprobe that we use in our institute, and it's around 2.4 millimeter in diameter, and it can be used in rigid as well as flexible bronchoscopy. And what they do, they touch the probe and they freeze it and then take out the tissue. To discuss in a very simple way, they do it like this. I will tell you the exact mechanism. But the problem is the risk of bleeding, because we are not cauterizing the tissue. So we are just freezing the tissue and taking it out. So the risk of bleeding is more as compared to electrocautery and PC. But the advantage is we need not reduce the FiO2 with cryo. So the thing is that the temperature at the tip of the cryoprobe is rapidly cooled to extremely low temperatures, typically minus 79 degrees centigrade using carbon dioxide, or minus 89 degrees centigrade using nitrous oxide within seconds. And why this cooling happens? Because of the Joule-Thomson effect, as the physics goes. Because the compressed gas expands and cools rapidly as a result of sudden pressure change, because there is a valve and suddenly the pressure changes and it causes expansion of the gas, and at the same time fall in the temperature. So it freezes. So when the cryoprobe touches the tissue, the tip is frozen, so it's stuck to the tissue. And when we pull the probe, the tissue also comes out. This is the mechanism. So this goes on repeatedly till the tissue is the area is free of the tumor tissue. Another method is coring. Coring is like with the rigid bronchoscope itself, we can just go dive into the tumor and take a bite out of it. Just try to remove it from manual by physical pressure, and the fragmented tissue is then extracted using a forceps suction or cryoprobe. So coming back to the case, they have done some electrocautery in this patient. As you can see, they are doing the electrocautery, and look at the amount of sparks it is creating. So there is always a risk of say airway fire, and we should always keep an watch on the FiO2. And at the same, after cryo, they can, in this case, particularly the index case we are discussing, they have used, after the cryo is done, they use the snare. This is also, again, you can see this is kind of loop, and it's a hot snare, like they are going to hold it, the tissue, if it is a pedunculated tissue, and they are going to force it with the cautery. So this is a hot probe. So once they have done it, they use the cryo extraction. Cryoprobe for extracting the tumor, because now the tumor pedunculated part is sitting there idly, and they had started, now they will put a cryoprobe to take it out. So the cryoprobe goes in through the side port of the bronchoscope. Sorry for the little disturbance in the image video, but I think it is still, we can understand this. So this is the tumor. The probe will be coming in a short while. Yes, the probe is here. So it's going to touch the tissue, and they are going to start the probe, and the area will be frozen. So now you can see the ice is being, then they are going to take it out. So they are pulling the probe as well as the tumor tissue out through the rigid scope, then through the, they will take out the fiber optic scope. And see, you can see the fiber optic scope with the tip, with the cryoprobe, with the tip with the tumor. Now they are going to thaw the area so that they can easily dislodge the tumor from the cryoprobe. And the important thing is that during this time, the patients, that area, raw area inside the bronchus might be bleeding. So it is very important to go in fast to see whether the tissue is bleeding a lot or not. So they have gone in with the fiber optic bronchoscope again, and just to check how much is the bleeding. And if it is bleeding a lot, then they have to manage it with cold saline or some medicines like this phenylephrine. They can use adrenaline in diluted solution. They can use tranexamic acid. So these are the various options available. So post this is now the bronchoscopy is done. They have removed the tumor and all, and they have taken out the scope. So following the bronchoscopy, it is the rigid bronchoscope is withdrawn, and the patient's oropharynx should always be suctioned thoroughly and inspected for any potential injury. If there is a dental injury, if there is a soft tissue injury, we should always note it down and try to control it. And further, airway management and ventilation is via a supraglottic device or endotracheal tube or manual mask ventilation. It is important that post-extubation respiratory distress can happen, and we should turn the patient to the predetermined rescue position, ventilate the patient, or maybe reintubate the patient. And if it is still, we think that there's some major blood bleeding is coming out from the trachea, then we should always be ready with the reinsertion of the rigid scope and then see what is happening. Complications can be many, like major bleeding, dental injury, soft tissue injury, complete airway obstruction, airway perforation even has happened, pneumothorax, and then pneumomediastinum, and then gas embolism, hypoxia, hypercarbia, arrhythmias that can happen. So couple of important problems that we arise is the circuit leak. So circuit leak can lead to hypoventilation, hypoxia, hypercarbia, and awareness. With the instrumentation port of the rigid bronchoscope open, it is an open circuit. So we need to block it. As you can see in the image, we have we can block the various ports that are in the multi-head connector with manually or with the cap. Then we can always pack the oropharynx also with some gauze so that the leak is less. And we can sometimes use the oxygen flush. And in this connection, it is very important to have the ambu bag in handy because it's a self-inflating bag. Because oxygen flush is also sometimes not very controllable. We can ventilate with difficulty. So and we have to repeatedly flush it, and our hand is engaged. But with the ambu bag, with the oxygen connection, if there is no fire, no cautery, or they have not done anything, only with the ambu we can manage it very nicely. Bleeding is a major problem. Again, we have discussed. So problems of bleeding is that we have to terminate the procedure early. Inadequate sampling can happen, and decreased diagnostic accuracy, and even death can happen because of the bleeding. So patients at risk are mainly vascular tumor patients and severe pulmonary hypertension, SVC syndrome patients, and like comorbidities like uremia, coagulopathy. These patients are at very high risk of bleeding during the procedure. How to quantify bleeding? Less than 50 ml is called minor, 50 to 100 is moderate, more than 100 is severe. But this is very difficult to understand because they use a lot of saline, cold saline to flush out and everything. So it is very difficult to say how much bleeding has happened. So important, the other criteria is mild, moderate to severe. Mild is only with normal saline, 0.9% normal saline, 2 degree to 4 degree centigrade, or epinephrine solution, they can manage the bleeding. This is a mild bleeding. Moderate bleeding is, in addition to that, if you need an APC or a bronchial blocker, that to be used just to control the bleeding, that's a moderate bleeding. Severe bleeding is like we need transfusion, use of vasopressors, rescue surgeries is needed, and prolonged mechanical ventilation. This is kind of severe bleeding. So there are various options available like cold saline, adrenaline, Trenexa, and all these things can be used for. And on top of that, we sometimes have this hemostatic balloon catheters, which is not available with us, but then these are available in the market. Another important risk factor is the risk of airway fire. It's a rare but potentially serious complications. So always use a low FiO2, 0.4 or less. And if needed, just we can give some apnea or less than 0.3 even if it can go. And important thing is cryoprobe can be operated at normal FiO2. If we are using the Z ventilation, we should use the laser on button. And most important thing is the communication between the anesthesiologist and the pulmonologist, that we are going to use the cautery, we are going to use the cryo, or we are going to use that APC. So these communications should be FiO2 is how much is the FiO2, FiO2 is down or FiO2 is normal. These communications should always be, and this is the flow chart of the NICERA, which tells us what to do. I'm not going to go into the detail what to do in case of an airway fire management. So the key points are it's a teamwork, and team members should be well versed with the plan, and pre-procedure briefing is very important. When the patient is before the patient comes to the OT table, we should always discuss out what is the pathology, what they are going to do, what they expect us to do, and what are the options we have. And be ready with the unconventional mode of ventilation. TIVA is generally preferred over inhalations, and prepare for any emergency, airway emergency, loss of airway, bleeding, fire, and identify the rescue position of the patient beforehand. So it's important to understand that endoscopic debulking is not a definitive procedure. it is mostly a palliative or a bridge to a definitive procedure. This is very important to understand. Approach, and we should always approach it that way only. And aggressive intervention compromising the patient safety is not warranted at all, because as I said, this is mostly, and 90% of the times is a palliative or a bridge therapy only. So that's what I wanted to present. Thank you, ma'am.
Thank you, Dr. Das, for that excellent overview on these bronchoscopic procedures, which usually are maybe done outside the OR settings. The anesthetist may be alone. So I think it's extremely important for him or her to be well versed with what is there, what are the problems that they can face. And it's a kind of a procedure which asks for us to be vigilant all the time. So I think we can now take up if you have any questions. So I think there is this one question for Dr. Akhil. Dr. Akhil, can we railroad a DLT over the bronchoscope? How good or how successful will it be?
Normally in routine practice, we generally don't really railroad the DLT over a bronchoscope, because in multiple studies which have been conducted, the blind method of insertion can achieve the first pass successful placement around about 90-95% of the cases. And the other thing is that when you railroad the DLT over a bronchoscope, the time taken for proper establishment of DLT is longer. It is around about 4 to 5 times longer. As I can recall by a study by Busek and et al., that the time taken when you do while the railroading, it is somewhere around 181 seconds. Whereas in normal conventional thing, the time is somewhere around 40 to 50 seconds. Moreover, in cases of difficult airways, where you get a Cormet-Lehan grade 3 or a grade 4, or in cases of distorted anatomy, when you have a fibrous lung and the normal carinal shape is totally distorted, at that moment of time, railroading the DLT over a bronchoscope would be very successful. The other thing what we need to know is that the size of the bronchoscope which you are putting up in these DLTs, they are very small, and it is a very costly equipment. So there are studies in which they have shown that while railroading a DLT over a bronchoscope, the bronchoscope has got torn and it has become dysfunctional. The other problem which can come is that suppose it's a very large trachea and the 3.8 size ambuscope is on the left side and you're trying to put the bronchoscope into left side. Because of a distorted anatomy, the tube might still go into the right side and there will be a recoil of the bronchoscope and it will get bent. So in my personal practice, I always like to put it blindly first, and then to the tracheal side, I would like to check where my tube is. And if still I'm unable to achieve the proper placement, then I would like to put the bronchoscope to the bronchial side and then try to get the DLT over it.
Oh. Then this another question for Sudha. Sudha, what's the determining factor for extubation in a patient after bilateral VATS pulmonary metastatectomy taking 3 hours OLV on each side?
Okay, am I audible?
Yes, Sudha.
Yeah. If a patient had patient's pulmonary functions were within our normal limits, and if a patient was maintaining oxygenation and CO2 when we are doing one lung ventilation on both the sides, and when we have come back onto lung ventilation and we have done a good recruitment of both the lungs and patient is maintaining well, and then we can try a reversal and we can see if patient is taking adequate tidal volume, there is good effort and maintaining oxygenation, then we can definitely reverse the patient, no issue. It all depends upon the patient's lung respiratory mechanics and patient's already, whatever existing lung conditions are there, whether patient has a restrictive pattern or a normal lung mechanics, or patient has obstructive lung disease. It will all depend on whether how the patient's pulmonary functions are.
Yeah, so I think, see, our aim should always be to extubate our patients rather than shifting them intubated, because most of the studies have shown that the post-op pulmonary complications will definitely be higher of a patient going on the ventilator. So, I mean, although textbooks would say that OLV of more than 100 minutes and all is harmful and all, but in our practice, we have seen that irrespective of the duration of the OLV, unless there is some contraindication to extubating a patient, I think we should always give them a trial of extubating them. Unless, other than the fact that if he's hemodynamically unstable or on high dose of inotropes, which may otherwise tell us that no, this patient should be sent intubated to the ICU.
Yeah,
So
definitely. In most of the cases, we do extubate the patient, and if it's just a metastatectomy, so they're going to resect a very small segment
segment,
bilaterally. Yeah.
yes.
So if the rest of the lungs are normal, so there is no harm in extubating these patients. We can definitely extubate. As I said earlier, if there is any problem with the rest of the lung, then obviously we might face some issues. Otherwise, if there is normal lung and it's just a metastasis, we can definitely extubate these patients.
So this is another question for Dr. Akhil. Dr. Akhil, lung isolation technique in a 5-year-old girl for lung metastatectomy weighing 15 kg.
Ma'am, in this patient, most likely my option would be using a bronchial blocker, which is parallel to the endotracheal tube. Because in a 5-year-old child, if I am going to use a 4.5 or a 5 size tube, I won't be able to pass in the bronchial blocker as well as the fiber optic bronchoscope through the same SLT. So normally what we do in such cases is that after normal laryngoscopy, we first insert the blocker somewhere around, according to the length of the trachea, somewhere around about 13 to 14 or 15 centimeters. Then we pass in the single lumen tube. We inflate the cuff of the tube. The cuff of the tube acts as the anchor for the bronchial blocker. Then we do a fiber optic bronchoscope. And then with the help of the mechanism of torque control, we can either shift it to the right side or to the left side. And then we can achieve a good lung isolation.
Yeah, so I think placing the blocker outside the tube
Outside the tube
is would be preferred, because we do not have a small sizes DLT, so we will not be able to use a DLT for isolating the lung in these patients. Okay, again, the next question is also for you, Akhil. How do we make out incorrect positioning of the left DLT in right bronchus with bronchoscope? Instead of entering left bronchus, we have intubated right bronchus. So how to confirm if we have correctly placed the tube or need repositioning?
See, when we do a FOBA, normally the first step, what I normally do is that I pass my scope to the tracheal side. So when I will be passing my tube onto the tracheal side, the moment the tracheal end ends, after that I would be seeing the endobronchial lumen, and I won't be seeing any passage for my bronchoscope to be going. Because on the right side would be the tracheal wall, and on the left side would be the bronchial lumen, which is going onto the right side. So in this case, what happens is that then you do a FOB to the left side, and over there you will classically see the 3 vertical openings of the right bronchus intermedius. So then you will come to realize that you are now in the right side. So while keeping the FOB in place, you will now withdraw your double lumen tube till you see the carina, and then you will pass your FOB onto the left side, and you will railroad your DLT onto the left mainstem bronchus.
Yeah, thank you, Akhil. I think that's all for the questions that we have. So I think after this, I think we can just come to the end of today's webinar. I think all the points have been covered by all our speakers really well, starting with Dr. Namrata, who actually told us how we should work up our patients who come for surgery. And I think she really highlighted that with the help of the three examples, which tell us that, we need to individualize our, pre-op workup for all our patients. It cannot be the same, and we should not just cancel a case based on numbers. We have to go beyond the numbers and see how our patients are, and that is the way we can decide whether they will be doing well or not. Okay, there is another question which has now come up for Dr. Das. Dr. Das, carbon dioxide retention is an issue in bronchoscopic debulking. How do we tackle that?
Yeah, so this is a real problem, but then as I already have discussed, we can always ventilate the patient with the side port of the bronchoscope, either use a circuit with 2 manual ventilation, or if you have a jet ventilator, you can use it. Most of the centers don't have a jet ventilator, but you can always go ahead with the manual ventilation, or at the same time try to improve the ventilation by blocking the side ports of the multi-head connector, as well as we can always pack the throat of the patient with some packing, throat pack, and generally this improves with this thing. And after the procedure, If definitely in between also, if we can think that it is now safe to take out the rigid bronchoscope and put an LMA or put a tube in between also and ventilate for some time, after some time give the patient back to the pulmonologist or interventionalist, we can do that. Otherwise, after the procedure, we can always put an LMA or mask ventilate or intubate the patient and ventilate for some time. So generally, this takes care of everything, but definitely CO2 retention is a problem. So if it is too high, then definitely we have to, in between you have to ventilate. Otherwise, at the end, we can do that. Or in between, we can, throughout the procedure, we can go ahead with the Z ventilator. So that generally, with the Z ventilator, that does not happen, because we have seen that till even half an hour to 1 hour of gen ventilation, the CO2 does not go up much.
Yes, I think that is important. If you have a jet, then generally it is not too much of a problem, but you can always break up your procedure into parts so that, at each step where you think that the patient is not bleeding, a part of the tumor is out, again, reinsert your LMA and ventilate them simultaneously along with your jet ventilation and manual ventilation that you're doing. So you have to, keep working towards that in between. Take out the scope, put in your LMA, ventilate the patient. So simultaneously, all these things need to be going on. Any more questions we have, Swastika? Okay. So I think then other than that, I think we've covered our lung isolation devices in detail, and Dr. Akhil has really shown us good videos. And I think there should be no doubt in anybody's mind as to, how to choose the size of the tube. And these days we also have the ultrasound, which can help us to guide and decide the size of the tubes if we want, and use them also to see the isolation, with the ultrasound, lung isolation signs can be seen. These are the new techniques and tools which are coming up. And Dr. Sudha clearly highlighted the role of protective one-line ventilation. And yes, we do have, it's important that she brought up the case of bullous diseases, because those patients really need an individualized, their ventilation will definitely be different from a patient who is undergoing a lobectomy, where we can use individualized PEEP, as they are saying these days, to ensure that we have the best compliance that is available and reduce our driving pressure to the least, because that has been found to really, help us to maintain our one lung ventilation period much longer, as it would have otherwise been when we were not using driving pressure ventilation. And then finally, I think Dr. Das has clearly covered the topic of rigid bronchoscopy, and the importance of knowing what devices are used is also important for us, and not only for the pulmonologist, because it really tells us what the complications that patient can face, because your patient can have an embolism with an APC. They can develop fires. So to ensure that your oxygenation is kept low. Another problem when you're using the cryo, because it's a blind area, there have been case reports where they say that the pressure exerted by the cryo is so much that it can tear a piece of the trachea or the bronchus, because that is the force with which it pulls out the tumor tissue. So these are real complications which have happened. So it's as important for us to know the anesthesia, as important it is to know what are the gadgets that are being used, so that we are well aware and well versed to what the problems that we can face, especially if your bronchoscopy suite is away from the main OR and you are the only anesthetist alone providing care in those areas. So, ma'am, Dr. Ma'am, yes, ma'am.
Hi.
So,
Hi.
yes.
Yeah, I've been listening to the whole webinar. So this thing was with so much interest, really was completely engrossed. And I'd like to, all the points have been covered so well and moderated so well by Dr. Sangeeta, that actually the webinar should have been thoracic anesthesia made easy, which sounds very, very easy, but I tell you, the challenges that are there, hearing your lectures, and we also practice it, we really know what a challenging job it is. So thank you so much, Sangeeta, for the lovely moderation. And thank you so much, Namrata, Akhil, Sudha, and Jyotirmoy. That is so nice of you to take the lectures. They were so clear and discreet that there's no doubt left among any one of us for any of the queries. Thank you so much. Thanks, Swastika. Thank you so much. and lovely to have you all today. Thanks a lot.
Thank you.
And good night.
Good night, ma'am.
Thank you.
Thank
ma'am.
you.
Thank you,
for the
ma'am.
opportunity.
Thank you so
Thanks
much.
to all the dignitaries present here. I would like to thank to everyone. It was a very much wonderful and informative content. Thank you for giving us this opportunity to host the session, and we hope to have you again in our platform very soon. So thank you so much and good night.
Thank you.
Thank you. Thank you.
Good night.
Thank you very much.
Good night, everyone.
Bye.